Welcome to Halteres Presents, a brand agnostic interview podcast that seeks to objectively highlight the happenings within the world of diagnostics. And now, your hosts, Thayer and Mickey Urdea.
Hello, and welcome to Halteres Presents. My name is Rich Thayer, Managing Partner at Halteres Associates.
And this is Mickey Urdea, the founding partner at Halteres Associates.
Today we are joined by Dr. Donna Wolk, Division Chief, Molecular and Microbial Diagnostics and Development at Geisinger Health Systems. We had a fascinating discussion with her, ranging from over-the-counter testing needs to wearables to decentralized testing in other hospital environments.
We've had an opportunity to talk with Donna a few times over the last few years about a number of subjects in diagnostics, and she's a wealth of information. And now, our discussion with Dr. Donna Wolk. Hello, Donna, and welcome to the podcast. We're really happy that you were able to join us.
Thank you.
Would you please take a few moments and just give the listeners a bit of your background?
Sure. I'm currently a division chief for microbiology and infectious disease diagnostics at Geisinger Health within the Diagnostic Medicine Institute, where we sit with radiology. I did my postdoc at Mayo Clinic in Rochester, Minnesota, in medical microbiology, and my PhD at the University of Arizona. And so I'm an undergraduate medical lab scientist, so I've been in laboratory medicine since the 80s. It's a passion of mine, along with, my family who rates above that passion, but that's pretty much it. I do have my master's in health administration, which gives me somewhat of a different view from, I think, the straight scientist population. And I use that degree sometimes more on a daily basis than I do my scientific PhD, but it all works together. Thanks for having me.
Thanks. And it's because we are aware of that different perspective you have that we invited you to the show. We expect to get a different perspective that we have from others. So thanks again. For many years now, we've been hearing about the potential benefits of introducing decentralized testing. I know this is something that you're quite involved in. Decentralized testing includes so-called point-of-care, near-patient testing, and even over-the-counter or OTC, and at-home testing, pharmacy-based tests, and similar venues. It's just amazing, the explosion of all these test types. What are some of the examples of balancing these testing options that you've seen, and how well does the balance actually work?
Yeah, so it's interesting because, I personally have long since thought about laboratory testing as actionable versus not actionable. And so I've based my career on test deployment on those premises. And, before there was a lot of home testing in infectious disease, before we had the COVID pandemic and all these new things deployed, basically the first pass at actionability was, do you send your data and your samples to a core laboratory, or do you integrate them into an integrated delivery health network, which I'm used to working in? Because, from my perspective, if something is actionable, which means there's a downstream action, whether that's antimicrobial stewardship, improved care, reduced cost, reduced length of stay, I look at those buckets as clinical, financial, and operational variables. So bed management, for instance, that's an operational variable that is predicated by integrating your rapid HAI, hospital-acquired associated infection testing, into the different hospitals in a system, or different freestanding emergency rooms where people might get admitted, and those types of things. Then comes along, the COVID pandemic, COVID-19 pandemic, and now all of a sudden we have more than pregnancy tests in the drugstores, right? And so, I have deployed molecular on-site point-of-care infectious disease testing for many, many years in our large outpatient clinics, in our larger urgent care sites, where simply because of the impact on antimicrobial and antiviral stewardship. So our publications show that while providers tend to react to the news media, if the news says it's a bad flu year, well, then they act as if it's a bad flu year. So I wish there could be some communication, right? Because they seem to have more prudent stewardship, although we haven't proven this definitively, um, on a good flu year that's not so predominant than on the ones where they say there's a vaccine miss. And I think that's predicated for the most part back to, people who trained years ago that had rapid antigens and, oh, well, I don't trust that rapid antigen test, so I'm going to give antivirals anyway. And, so we in the laboratory, I mean, I make a lot of phone calls and say, hey, I saw there was a positive flu that wasn't treated, and it could have been. I saw there was a negative flu that was treated. Do you realize our test is 98% accurate? And they're like, oh, no, I really didn't. I just thought they were no good anymore. So I think, that's something that the laboratory, the messaging really has to get out. So that's a cost saving. It's also a prevention of medication salvage in case there is another flu pandemic on the horizon. I mean, that's what I was prepping for, was avian flu coming in the in the last decade, but that never came. COVID came. But it's the same kind of thing. Like, how is your system prepared? And do your clinics have the ability to do that? Because in the surge potential, you need to be thinking about that in addition to the home testing or the pharmacy testing. So I don't know if you have any other questions about sort of the hospital concept of point of care or actionability in the large clinics. If you do, I'm happy to answer. And if not, then I'll move on to, sort of the pharmacy and home testing and other point of care. So then along comes the COVID pandemic, and we are faced with options for in pharmacy testing, uh, at home testing. And I've had experience with some of those methodologies. I think there are obviously pros and cons to that concept. The inability to track disease after home testing becomes widespread is a real issue, and that's not just with the pandemic. That's with any public health threat. We don't know what we don't know if people are doing home testing, and that's not reported in anybody's medical record, and it's not reported to the Department of Health, and it's not reported to CDC. So one, I love the flexibility of it and the convenience. I mean, I have a stack of them at any time in my own home, along with my, Theraflu Keurig cup to get me through the flu season. But, I think, that's a general premise that this country hasn't cracked yet. And I think it's important because we can't, our dashboards, all the tracking that we have built to look at the epidemiology throughout, our integrated delivery network, and other people have the same approach with dashboards and tracking and state and national, reporting systems. They just go kaput when you have all these home testing. Furthermore, like from our perspective, why we put things in the point of care in our clinic system is not only for stewardship, but also we focus on population health, right? So if we have coverage from a health plan, if I'm making a decision about this and I want, you know, we cover a lot of people with our own health insurance. That's not the same in other cities, but the general principles of population health still apply. If you've got somebody who's not identified with flu or RSV or COVID, and they go to school or they go to the neighbor's house, now the healthcare system in that city has to absorb, well, maybe that kid, it will just get better on their own, but maybe their pregnant mother or their 89-year-old grandmother will get sick and get hospitalized. So the untold costs of that not focusing on the population health by putting out tests that are less than accurate is an issue. I mean, and I think the balance of speed versus the local laboratory time is an issue. We saw the turnaround time in COVID was weeks sometimes. In our system, I set up a triage so that inpatients would get their testing, within an hour and a half or less. Then we went to the less sick or, ED, inpatients, less sick inpatients, outpatients, pre-surgical. This risk stratification doesn't apply to the community where the home testing is going on. And so you can't give, because maybe somebody has a high complexity disease and deserves a true 95, 98% accurate test. You don't know that. They buy it from the counter and they take what they get. And, some of the over the counter tests they say they're 90%. You know, for example, when the COVID bioburden went from sky high down to sort of a normal level of virus, the accuracy of some of those tests was not so good. The other thing you have with either the point of care done by non-laboratory scientists, performed by non-laboratory scientists, is you need to keep up with the quality control and the oversight and competency of those folks, and you can't do that in the home, right? My bar for a good over-the-counter test is one that my 89-year-old mother can perform with ease and get the right result. Now, I found one of those and I buy it for her because it's more expensive than the others. And the other one is that probably my 4-year-old grandson could probably do the same test and get the right result. So there's not that many tests on the market that are like that. And so then you have the testing variability. Um, I noticed during the pandemic when I was supporting nursing homes, the population that's testing at home is aging in the United States. So is our workforce. I've got to get a magnifying glass to read some of the instructions. Some of the tests are, and those are simple things. And it's kind of like, oh, we can sort of laugh about it, get out your magnifying glass. But the truth is, that's preventing other people from protecting their loved ones. If you get a false result, you can't protect your loved ones, your babies, your aged, or your neighbors. And that is really a population health perspective that I own in my decision making, along with the precision medicine perspective that I talked about of targeting the right organisms so that you can give appropriate therapy or not, and do salvage of antimicrobials and save it for the people who really need it, which is really important in a pandemic or epidemic where antimicrobial or antiviral scarcity could be a real issue. So I think, it's great, put it on the shelf, sell it. But the truth is, there's a phone number to call, staffed by somebody who has a script to read. And so you really have to look at the entire area that you're servicing. That's what I do as a microbiologist, and say, how can I get the best test in a risk stratified way that, the people who need accuracy the most are encouraged to get that accurate test, and the people that can, kind of, you think that they can do the testing themselves, they could use that. So we have supported home testing. I have in our employees. That's another thing. We have medical professionals who are struggling with some of the point of care testing. We have people also not believing in the pandemic that are swabbing their countertops or their dog's mouth. When you are selecting a test for the general community, no matter how educated or young they are and how good their eyes are, I feel that it should be mandatory. I feel the FDA should make it mandatory that there's some kind of internal control that's not just did you add the drops, but actually says, did you get the sample? Because we were having experiences with people purposely trying to create false positives, purposely trying to create false negatives. And unfortunately, this has become politicized. Infection has become politicized, and it shouldn't be, but it was. And so when I think about what tests to deploy and at what place, ED, ICU, other inpatient, outpatient, home, mobile testing, pharmacy, all those things come into play. I will say that I've had a really good experience with pharmacists that I've worked with personally. However, I've also seen, as has many people that I know, that will go to a drive-through pharmacy clinic and they'll come back and say, Dr. Wolk, isn't it supposed to be like, isn't the nose swab supposed to go up in there? And I'm like, yeah, why? What happened? Well, they kind of did a nose hole culture. And I'm like, well, that's apropos. Let's get that nose hole culture because that's going to be false negative. It's not. And these were trained pharmacy or public health people that just had to be hired for the pandemic. So I think our messaging lacked and will continue to lack until we pay attention to all of those factors that we talked about.
Yeah. We've had a lot of experience with these instructions for use in, for instance, Africa. And it's just amazing how many mistakes people make that people don't take into consideration and have to redesign those IFUs.
Yeah.
So as a follow-up, I'm just curious, how do you think about the issue, the fact that for at least COVID and flu, you need to take the antivirals if you're going to use them in the first day or so? How do you deal with that with regard to the testing regimen?
Well, I've worked in all the places that I have worked in my career to try to release results quickly to the patients so that they can have some ownership in their own healthcare. I think if you give people the right information and the right apps or the right patient portal, people will look and they kind of get the sense of they tell their neighbors, oh, I got my test back in 6 hours or I got my test back in 1 hour. So people are starting to look on those kinds of things. I think that that ownership of you do have the flu and here's your little piece of information. What you can do to help yourself is take your antivirals. What you can do to help your family is take your antivirals because you won't be shedding and transmitting and you may prevent infection in a loved one. I think that as microbiologists, we don't, we're very good as a nation for the most part in the analytical space. The pre and post analytical seems is our responsibility and our duty, and it seems to be a little bit lacking when it comes to terms of speaking with the public. Number one, we don't speak in that language on a day-to-day basis in our jobs, so it has to be adapted for any kind of self-collection. You have to understand that one, you need diversity in your languages. Two, you need very simplistic and relatable circumstances when we're talking, and that goes, genital self-collection is even harder to describe than nasal turbinate or those kind of self-collections, finger stick, whatever. I just think that there has to be laboratory specialists that help with those kinds of things, because I read some of the self-collection guides from across America, and I'm like, again, my mom, I say, could she understand this at 89? Now, I will say that she's a little unusual. The woman has an iPad and an iPhone and an Apple Watch, and she goes to senior Zumba and drives herself. So she's not the typical 89-year-old, but her friends are. And so I kind of use that bar when I'm trying to learn how to speak to folks. And then I always take things through multiple languages depending on our patient demographic. I think we have to, in this in this realm of point of care testing or at home testing, yes, it's accessible if you have the money to buy it, right? So not everybody has a car to get to the drugstore. Not everybody has, so the home delivery systems are great, but again, they're more expensive. I think about equity and diversity and the socioeconomic impacts of what I'm dealing with when I'm talking about a point of care device, whether it's in the United States or another country. I'm more familiar, obviously, with where I live in the United States, but as you said, every country is going to have its own nuances, its own social norms, and you really I think the diagnostic industry really needs advocates that understand people, what makes people move. Behavioral integration units are now becoming common in the value-based care. And in this point of care space, it's so needed. What is going to be the trigger to get that person to buy a home test and do it at home? I mean, is it going to be prep therapy that they want to get into and they have to test negative? And if so, then how do you prove it's negative so you can give them the prep therapy that they need? Um, None of these things hook into the medical record. The one or two I saw that did were way beyond the money capacity of most regular everyday people on a routine basis. So if you're a prep patient and you're thinking, well, okay, I can self-collect or I can even self-test and then I can get my meds, you still have to be a relatively wealthy patient. And I think we need to do a better job of creating equity among that kind of a scenario if we're really going to do public and population health appropriately.
Wow. Lot to think about, a lot to unpack there. Maybe we can shift gears a little bit. What are some of the factors you suggest people weigh when considering whether to offer a test only via typical laboratory testing service, such as a hospital or a reference lab, versus other point of care decentralized healthcare settings, such as in a clinic or pharmacy?
My approach is to always look at value to the patient of on-site testing, and that relates to some of the first things I talked about, the actionability of the test. What is in that for the patient? Can they get access to antivirals sooner or antibiotics sooner? We know from the social science literature that once people have a diagnosis, they're happier, they're more engaged. It affects their patient engagement score. So I think about those kind of things because my approach has always been sort of put the patient first and then think about your own infrastructure. Do you have the capability to perform the kind of test in-house? Is the test volume present so that you're not performing more quality control than you are patients? Because that's not really cost beneficial. What's the turnaround time on the reference laboratory? As I said, some of the reference laboratories were, I hear, taking, up to 14, 21 days and in the first and second waves to get reports back. That's not an actionable test in anybody's mind. So that's a little bit of a one-off scenario. However, for-profit venture capital funded reference laboratories all have delays because you've got to get the specimen to them and back. So that delay has patient impact, it has therapeutic impact, but in some cases it also has other downstream impacts like mortality, which you can't really put a price on. It has impacts for length of stay and test stewardship, diagnostic stewardship, if you want to call it that, because we don't only think of laboratory tests, but X-rays, respiratory therapy events, things of that nature, along with the antimicrobial stewardship. So I think all those things have to come into play. And then, of course, you get down to workflow in your laboratory. Do you have capacity? Does it take another instrument? Do your technologists have the skill set, or is there going to be a big learning curve? How does it fit in with the rest of your test menu? Is it a one test pony, I like to call them? Or do you get a broad menu if you are going to purchase some capital? And then finally, what is the actual cost benefit when you look at the numbers and not just the return on revenue for reimbursement, which you may or may not get, but what are the downstream benefits that are recovered to a healthcare system in terms of readmissions or repeat appointments, provider satisfaction, which is critical now trying to recruit providers. So it may seem like a big, broad list, and it is, but those are the things that we take into account, or I take into account.
By the way, one test pony is a great line that we will use and credit you. That's a good one.
Thank you.
So Donna, coming out of the pandemic, we see that people all over the world better understand the role and the need of diagnostic testing. In fact, they're becoming much more comfortable with taking charge of their own self-testing at home. Over-the-counter or in-home testing, of course, came into prominence with the introduction of rapid pregnancy tests way back in the 80s. And now, of course, glucose monitoring. And now includes a wide range of health and wellness applications, including, of course, respiratory viruses, which we've been talking about, STIs now, hemoglobin A1C, and others. So, in your experience, what are the types of tests do you believe are well suited for OTC use?
So I think that, I'm very interested in the wearable. I am a controlled diabetic myself, so my little button tells me I'm in control or not in control. That doesn't always apply to infectious disease testing, although I do think there are, back in the 90s, there were people doing breath analyzers for different microbes and respiratory infections. That really hasn't taken off, but I think how cool would that be to have something pop the cap, breathe into it, and it tells you, yes or no, you have some kind of a respiratory infection or strep throat. I think about technologies that would be adaptable for vulnerable, the very young. The parents are trying to juggle. My own daughter has two children and she's trying to juggle work with getting them to the doctor if they have a fever. So things that could be useful in the home setting, I think are should be focused on things that would be beneficial to pediatrics, to geriatrics, to homebound people, to disabled people, because it's very difficult to get people in. So, mobile services, mobile testing services are sometimes a way to fill that gap in my mind because those same vulnerable people may or may not have caretakers that can help them do the test or collect a sample. And so, I do think there's a role for this. I, however, unfortunately think that a lot of manufacturers don't think through all those issues when they put something on the pharmacy shelf or ship it to somebody's home. In the infectious disease world, like I said, the breath, but you know, just as we have nasal swabs, is there a cut that's infected? Can we swab a cut and look if we have MRSA or not? Do I need to take my child for antibiotics or can I just use home antimicrobial cream or antifungal cream? Nobody's bridged that gap. And maybe it's not a market that people would make money on, but to me, those are kind of the things. The vital signs associated with infections, obviously, we all have thermometers in our house, but what if there's another biometric? I have a wearable ring that tells me I'm stressed and that my nighttime temperature is up. Is that something that could be deployed for the elderly and given to them as a part of their care? Looking at home care, at home hospitalization. How do we track that so that people can stay comfortable in their homes with infections or fever coming up? How does that track back to the medical record if it does? Because somebody has to monitor that, whether that's somebody stopping by every day, but ultimately, that may be a waste of time to have a home health nurse come in when they could have a wearable that alerts people to. And I know that people are doing that in the cardiology space with weight gain and other things. But the fact that my ring can tell me I had deep sleep or didn't have deep sleep, that my temperature was high elevated and I was stressed yesterday. I mean, is it 100%? Maybe not, but is it a sentinel chicken for certain infections? Like, I think those things are going to have to be evolving as we try to get the patient care closer to home and more easily accessible to everyone. I Not everybody can afford a ring or a button that tells you what your glucose is. And I think that we have to, again, I go back to the equity and the diversity of all of this because it can't be just tested in certain populations. It has to be tested in all populations. And, for a manufacturer, that's a heavy lift. There's a lot of money goes into to diagnostic accuracy for FDA cleared tests. And now we're in the world of LDTs. So a lot of the home collection is now perhaps going to be LDTs. How is that going to work? You clearly get the most accurate answer if your test is performed by an accredited and an expert laboratory system. But where's the wiggle room? And are we doing people a service or a disservice? Is it better to take the home testing taco truck around the neighborhood and collect the swabs and bring them back? Or is it better to have them home testing and can we put a GPS on that mobile testing truck. I'm tongue in cheek about the taco, or in my day, it was the ice cream truck, and everybody would run, right? So do we have drop off points? Do we have vending machines? I don't want a Coke can or a soda can. I want a nasal swab. I want my home test, and I want to swipe my card or put in a dollar bill and get my testing material. I think that humanizing the process, and I don't necessarily think that the big central suppliers of home goods, ordering from this and that and waiting the next day for your service is necessary in all cases when a local, to me, healthcare and particularly infections are local, because you have clonal viruses, clonal bacteria that is unique. So we have people that are unique, we have pathogens that are unique, and immune systems that are unique. So, how could we move forward in this, sort of the Jetsons world to say, okay, this has happened, but then we also have a marker that says, your immune system is okay. So if your fever's not XYZ, then, you know, drink a lot of chicken soup and water and kind of tough it out. So I think integration with family practice and care, and changing us from a visit-based acute care system to a wellness-based system with the point of care testing and mHealth applications that go along with that is really the key to the future of reducing costs, but it won't be without cost to get them out to the market. And they're going to have to be vetted for, cost benefit across a rural, metropolitan, the whole 9 yards. So you see pockets of testing services that are doing many of those things we talked about in the point of care. We're not all Jetsons yet, but I do think that there's going to be a day when we do have other things that can monitor and help us with whatever our chronic illness is or our predisposition. I'm exploring something that Dr. Katie Caney has written about the whole person index that includes, clinical, social, genetic, and behavioral impacts to your health. And I think that those kind of integrated messages, population health, public health, acute care, and wellness health, have to come together and talk to each other, because there's not a lot of venue for that right now, and everybody's trying to anticipate things that I was trained in acute care world. That was my world in the fee-for-service world when I was a young budding microbiologist, let's say. But now I have to develop different skills, and I have to think differently, and I have to think like a patient, which we never did before, but in the last 20 years, 15, 20 years, absolutely, we have to think that way. And the laboratory and diagnostic industry has to tell that message to CMS, to the FDA, to the general population, and to our CMOs and C-suites that this is how the laboratory can impact downstream care and wellness, closing care gaps and HEDIS score improvement, all of those things. Laboratory has if we do this right, and the laboratory gets that information from the home or wherever, then monitors and baselines and trigger points could be identified. I'm working on a project now with potential wastewater surveillance, let's say. So that's another sentinel chicken, the animal and zoonotic population, the insect and tick-borne population. Again, all those things have to come together, and right now there's pockets of this, but there's a lot of work to be done. It's exciting work, and I do think that we will have a better prediction system based on monitoring the wearables, the home health testing, the whole in-home testing, the public health testing, so that there are predictive models to let people know. Like, I'd love to say, hey, you're in the news telling me you're in county blah, blah, blah. Your risk for COVID-19 is elevated today. I get my allergy report every morning. When my Alexa tells me it's 6:30, I get the weather and my allergy report. There is a flu cast, but there's so many other things that could be incorporated that would inform people's behavior. Maybe you want to order your groceries this week because COVID is high, or maybe you don't. There's just so many things that go into this. It's kind of mind-boggling. But thank you for raising the questions.
Donna, you've mentioned wearables a couple of times. That happens to be a space we're lucky enough to have, done a little bit of work in. And one of the things we've come to realize is that hydration, dehydration, to be more specific, is one of the leading reasons that folks wind up in the hospital or having to go, to the ER, especially in the elderly. What is your experience with being able to monitor electrolytes and hydration, let's say in your mom at home, or in a skilled nursing facility or something, whereas the family you're taking more charge to look for
Yeah,
indications of dehydration?
it's a great question. I personally don't have any deployment from microbiology, but I will say also, being a controlled diabetic, I monitor my hydration like myself because that makes me hungry if I'm dehydrated. So they tell you that, sleep, hydrate, those kind of things. So I think those are all good preventative measures. For my mom and her hydration and her, you know, I had an episode with her actually where um, she came down with sepsis right at the beginning of the COVID pandemic. And maybe this is, you guys can cut this out if you don't want it. But, I called her. I was actually verifying the first methods and I was in the lab late at night and I just called to check in on her, see how she was doing. And it was about 6:30 and she said, "Oh, I'm fine, but I had a little, episodes today of like I had to go to the bathroom a lot." So I'm like, okay. So I called my brother and said, hey, maybe take some Gatorade over to mom because she said she may need it and check in on her. So I got home around 7:30 and I'm getting a call from my brother. What's wrong with mom? She's slurring her words. She is stuck in the chair. She can't get up. I can't communicate with her. And I'm like, I just talked to her an hour ago. So here, my mom had a UTI that was leading to urosepsis. And I said, brother, get her in the car, get her to the emergency room where I know they have rapid blood culture collection, where they know they have rapid identification of the bacteria on site in the hospital. So he drove her there and they got her in the sepsis protocol. She did not have sepsis, but she had a pretty bad bacteremia and was in the SIRS criteria for sure because she was incontinent at the time. Then she was, slurring her words. And, as soon as they hydrated her, to your point, Rich, she began feeling better, got the antibiotics in her. She was home in a day and a half, doing her normal things. But had I not called her earlier by chance and my brother hadn't had the time to stop in, you get these people that go down in the home. So to your point, a wearable, after that, I got my mom her Apple Watch because if she falls, then I get an alert. And so that family perspective, of course, is very important. Not all families have the luxury of living within driving distance, but remote monitoring of these things or, kind of public health monitoring of alerts that go off when something's different. I think with AI and interpreting those signals, I do think there will be things like that someday. I'll probably be long retired by then, but um, I look to the future to see how we can better protect our vulnerable populations, our disabled, our elderly, um, our food insecure, our uh, transportation insecurity, and really kind of reach out. To do this, you have to have internet everywhere. I live in a place that doesn't have cable internet. So I have another type of router. But you can't have equity until you have, all these things are great and they'll make some money from people who can pay for them. But where is that social equality that I kind of keep going back to because I don't think that we think about that enough in these endeavors.
Yeah. One thing occurs to us that about the wearables is that you have the opportunity to continuously monitor as opposed to occasional sampling, which
Mhm.
doesn't give us the full story. So there's so much to that.
Right.
becoming more and more important.
Right, before I had my glucose wearable, for instance, yeah, I was doing it every morning between meals, but you really don't see the spike. So you don't really have the learnings you need to say, oh, this apple makes me spike, but this apple has a lower spike. It's only through trial and error that you get that information. And, as a controlled diabetic, I am aware of my higher risk for infection. Not everybody is aware of that. Not everybody focuses on that. But wouldn't it be cool if there was an alert too, not just the bump that said, hey, you know, log this food, don't eat this again, kind of thing, or just alert you. And they do have alarms and things like that, but I kind of feel like that'll be moving forward into monitoring not only your glucose, but your fever and your breathing and your respiration rate and your heart rate variability, which I'm reading about now, which is a big thing in terms of resilience for somebody, and especially in the geriatric set. I mean, they need that because they may not have access to the kinds of things that everybody else does.
Yeah. Interesting.
Donna, recent shifts in the US from fee for service to value based care plans should, at least in principle, bring increased focus on both preventive and primary care services. In your experience, how has this impacted the need for diagnostics? Are you seeing an increased demand for decentralized testing in a growing number of advanced primary care clinics, urgent care centers, pharmacy settings, etc.? If so, what's missing?
So, I don't know if it's a pet peeve, but probably a pet theory. What's missing is it's not that we can't do it. What's missing is the analytics to get it. Missing is the interfaces to get it back into the record to be analyzed in real time and or over a longitudinal time period, and the analytic capabilities to say, this primary care practice brings downstream benefits to our patients and our bottom line. This practice does not. This practice does, but only if we substratify it by certain conditions. So, I actually think that the analytic infrastructure, however good it is, everybody brags about their data lakes, but I always ask them, do you have a data lake or do you have a data swamp? Because we had to curate our microbiology data, which was text-based up until a certain point in time. Microbiology worked with our analytics team here and at other places where I work to map over 14,000 organism codes because, as you know, microbes change names all the time. So you got to get them mapped to a LOINC code. Specimen types were typed in by hand. So I would see my data list and it would say arm left or left arm upper. So all those things have to be coded to a SNOMED code so that when you look at I have kind of coined a phrase called diagnostic intervention, an actionable test result. If you want to document that, you need two things. You need that curated, laboratory-centric curated data capability, which we do here. We started in the laboratory, and then we pull in interdisciplinary subject matter experts from all fields: nursing, providers, finance, health plan. I've curated a set for every body site and infections in every body site. Now I have the capability to say, if I start doing a point of care test, what's the impact? Because I've got standardized cohorts, I've got well curated data sets that I can actually show the value to value-based care. This is very unusual everywhere, especially in the microbiology community. But I find it very helpful in my clinical decision making. And as I develop clinical decision trees for actionability, which one and monitor their impact. A lot of this value-based care initiatives, which I will say, in the 10-year period that the country wants us to switch to value-based care, we should be at 50% of organizations right now, and we're nowhere near that. We're halfway through, and there's There's so much to do. But I will say, if we want to get there, we need to have laboratory and diagnostic scientists who have data analytics. I trained my own team, but it has to be incorporated. Like, we have to go back to the medical lab science training programs, to the pathology residencies, to our new providers, whether they're medical or laboratory, have to be well versed in the value-based care initiatives and document the impact. Not just so what I see is somebody will take a funded study, and then a university will have, master's degrees students and other students and PhD students that are basically free and are there for a snapshot of time. And they'll go into the charts and they'll grab a couple records and they'll say, this thing works. And then that's the end of it. The hospital or healthcare may not ever do it again. They've got a great publication, but then you call them and say, hey, I have some questions. Oh, we don't do that anymore. That was just a study. So that's like discouraging to me, very discouraging. If we really want to crack this, it needs to be something that is deployed with scientific approach, implemented, documented the impact, and then monitored. Because just like a simple blood culture contaminant, your phlebotomists are doing everything great. And then COVID comes along and then your blood culture contamination rate, so there, dips or rises. So in value-based care, you can't just do it. You have to do it consistently. And to do that, the analytic infrastructure has to be there. And there are places that publish and do all kinds of AI and machine learning, and I do too. However, it's really the simple things and keeping an organizational diary. That is so key. If I want to prove laboratory impact of a new algorithm or a new test that I have, whether it's point of care or not, I need to know what the emergency room was doing, what the pharmacy introduced into their formulary, how the sepsis coders were coding things differently, and when those dates happened. Because as healthcare, we do pragmatic investigation. We don't have a funded NIH grant that starts and finishes most of the time, or a funded industry grant. We have real life. And so, if I include a time period for analytics that includes a major shift in the rest of my whole organization, I don't know if the laboratory or the diagnostic had any impact or not. And if we don't talk to each other, then nobody knows. So there's a lot of detectiving work. My whole analytics team is constantly monitoring for, announcements that go on our webpage and things that come to us by email to say, oh, that could impact our study. Mark that down, date and time. So we do a lot of detective work. And honestly, that's what diagnostic and laboratory medicine people are great at. It's something that we could add value to value-based care in our organizations if leadership stops seeing us across the country, not just my personal leadership. Obviously, they're ahead of the curve with value-based care. But the laboratory is seen as a transactional element. If you read some of the publications from Clinical Laboratory 2.0 and the premises, we're not sample in, answer out. It's not transactional. We can do better if we look at the baseline and then introduce the point of care test and then look at the actual outcomes. And they may not be great all the time, but you have to do that cyclical improvement, like a quality improvement cycle. Maybe your providers didn't get it right away. A good example are these new wave testing for risk stratification. Providers want an answer that says E. coli or positive or negative. Risk stratification is a tough thing. And as we move into value-based care, there'll be more and more risk stratification, not only for the patients and who do we spend the highest technology dollars on to create an improvement, and who doesn't need that high-end test, we talked about that in the point of care space. So all of that means that the laboratory curation of an electronic health record, everybody has a data lake, but very few people get the laboratory involved. And if you're not a laboratory scientist, then you may or may not understand the 12 different HIV tests that are out there or the 5 different carbon dioxide point of care tests that are out there. And so there has to be harmony and cooperation within the health system, and especially with the outpatient arena with our family practice and our population health colleagues across the country. I do think that diagnostic accuracy is very crude in its understanding, especially because the laboratory has its, I mean, I actually wrote a little newsletter. Laboratory has its own definition of diagnostic accuracy, and providers have a very different one. Diagnostic accuracy to them is, okay, if I've got an X-ray and a lab test and a this and a that, they have their own parameters, and yet the terms are interchangeable, and it causes a lot of confusion.
And then what the physician is going to do with the information too. They have that information about that risk group at
Mhm.
hand. They'll make a better decision.
Yeah. I mean, people are trying to do that a little bit with the Epic or other medical records, where my personal work has done it with people that are at risk for bad outcomes for influenza. So we started this AI project before COVID, obviously. So we went through our whole entire population and worked with a group out of Israel called Medial, um, who has an AI, healthcare AI functioning company there. And we got a grant to look at risk stratification for people that didn't have a flu shot, but would be most vulnerable to hospitalization or death or bad outcomes if they got the flu. So we never raised our vaccination rate in 20 years here. But when we started to personalize the letters and the text messaging and the patient portal results to say, you are high risk, so we really think you should get your flu shot, or you are intermediate risk, or you are, we stratified, we created a risk score based on all the AI of that population that was, and compared the vaccinated and unvaccinated and all that good stuff. But every person that has a primary care provider gets a risk score in every August. And then those letters go out and text messages and whatnot, and then nuances of how to nudge. We call it the nudge unit. We work with the nudge unit. How to nudge the people to actually come and do it, how to make it easy for them, whether that's drive-through clinics, whether it's they're coming from another doctor's appointment. So now we have a pop-up in the medical record, which I think is what you were getting to, that when that person comes in for a wellness check, they'll say, hey, your patient's high risk for flu. You better try to get them the flu shot. Um, and interestingly, what we found out is that the people at highest risk, the top 3%, we're hoping this goes into, I think the nudge unit is putting it into JAMA for the deployment. We just had ours in the Journal of Clinical Informatics. But when you are high risk, those people kind of know they're high risk, and so they go. So really the sweet spot was, the top 10%, the 4 to 10%, and even into the 15% where, they're okay, I have a little risk, but yeah, I'm pretty healthy, I'm not going to go. But if you tell them they're in the top 15% or 10% of risk in the whole population, then all of a sudden they're like, oh, I didn't know that. Well, maybe I will go get it. And then you include the action there, where to go for that service. And we have statistically improved our vaccination rate over the last 4 years with that system, including the first year of COVID when there was no flu at all. And in a time when when the vaccines were very politically charged. And that's the only thing that has ever tipped the needle in wellness for influenza. And it was a big initiative. Right now we have to look at, okay, now what's the cost benefit? We do this every year. Now that we have flu back in our community, what are the costs of care for flu patients versus before we had the increase? And how do we parse out the cost benefit of that? Do we keep doing it or not? Because we're still not at a rate that, I would find acceptable, but nobody else is in the country either.
Wow. Very
Great example.
interesting. Yeah, I could spend hours chatting with you, Donna. This is all amazing, amazing commentary. Just love it. It seems clear that consumers are ready and willing to take on more self-testing. We've talked a lot about the pros and cons of that, Donna, but what are your recommendations for test developers seeking to develop the next generation of testing solutions?
So, I think that easy sampling is critically important, whether that's some kind of a micro sampler for blood, although we know that the small volume blood testing is not necessarily where it still needs to be, but that kind of avenue. Uh, Sampling, I notice there's very few swabs for nasal collection that have a stop point. So a young person could jam it and cause harm. An elderly person with palsy could jam it up their nose. I think thinking about the pre-analytical collection methods a little bit more thoughtfully is important for developers. Making it a fail-safe, making it safe, not including hazardous chemicals that would be around that some, child could get a hold of or somebody could inadvertently, use in an improper way. So that's one. On the analytical side, I go back to, can my 4-year-old grandson and 89-year-old mom get an accurate result? I mean, I think maybe I'm stretching that a little bit on the 4-year-old side, but honestly, that's the bar. People are busy, they're scared, they're sick, and they're not thinking in the same way or understanding things the same way they do as when they're well. So if you're an at-home or point of care test developer, that's important. If it's point of care in a hospital, then obviously that audience, phlebotomists, we're paying nurses and pharmacists that make a lot more money than health assistants and phlebotomists to do point of care testing. Well, they do it well, but so do the phlebotomists, and they belong to the laboratory side. And so I've trained phlebotomists to do some point of care testing, and they're excellent at it. And they follow QC because they kind of know what QC is, much better than some of the providers out there in the world and nurses. The pharmacists they're pretty good at testing. But again, we're paying healthcare dollars that don't need to be spent in that approach. So I would also advise people to think about the audience that's being tested. And then post analytically, oh, there's a whole list of things. The first and foremost is that we've got to find a way to get for people to upload. I mean, we can upload everything to our Apple Watch and why can't we upload these results that then go back into the medical record somehow? I mean, it should be pretty easy to do that if the right people are looking at it. And then we can really tell what's going on in our population because right now we're only seeing the tip of the iceberg. And the people who want to test, at least we could capture them. You're never going to get away from the people who decide I'm not testing, period. I don't want to know. I mean, that's the other issue with that is that people have become, we always just toughed out a cold in everybody's life. However, it's not just a cold anymore. I just read an article today that COVID is still more deadly than the flu, which is pretty deadly and ignored all those years. So like this is not a new concept and it costs lives, so many lives you could cry. And I mean MERS is the same way, hospital acquired infections. It's just it people become numb to the aberrant in our world and somehow we have to figure a way to shake them into reality to say, with a little bit of effort, this could be helped. And some of the things won't take a whole ton of money. Some of them will. So I think the post analytic, the getting the results to the provider or a family member who could take action, because right now there's no actionability in the home testing at all, because you can't control the environment enough. So it's personal information. It's lovely to know I've got to cancel if I have the flu or RSV or whatever, but not everybody takes that result with personal accountability either. So if you're not getting it uploaded somewhere, you know, then really what's the point? people are spending money doing this and then they don't do anything with the action. They still go to their party whereas if you had some kind of a provider communication, maybe it would seem more important to people. I don't know. I'd have to ask the behavioral scientists about that. But there are ways to the marketing and salespeople in our country have a million ways to get you to buy things. I've fallen ill to that myself, scrolling someplace and, oh, I'd like that book, or maybe I'd like that new tea I saw. We need to be able to do that in the healthcare community with actionable, accurate, low cost, accessible, and integratable, transmissible type of data pipelines so that we can get a grip on this. I think it's kind of the Wild West.
Very well stated.
I know you said you work in wastewater. Is wastewater a reasonable surrogate for that in any way?
I think I tracked advances in that in New York State and in Arizona where I used to live, and now working with some folks in Pennsylvania about a surveillance system. It's a traditional grant. I'm not sure we'll get it, but the idea that One Health vision of the CDC, that is a sentinel chicken that we haven't tapped. We also don't know with different diseases, what's the sentinel chicken? Is it wastewater? Is it ICU patients? Is it, because right now when there's an outbreak, the most common source of identification is and has always been the clinical laboratory. We've got salmonella in the Amerithrax investigation. We have anthrax that came from a clinical laboratory. However, we only see humans. And so that One Health um, sampling, it's not without expense, but somebody has to do the math and say, is it better for a state to sample wastewater and cow feces or cow respiratory saliva, whatever sample it is, or to have all these humans buying all these tests that don't really get aggregated and don't sound the alarm for anything? With with some of the New York State's interventions and identification of, I think it was polio in the wastewater systems. How great was that? It's on the news. People are like, okay, this is what I can do to avoid it. So you do have to have that messaging and kind of convert it to an actionable result. But the same could be said of, you know, bird flocks or cows or humans. And each disease might be a different sentinel chicken, but if people talk to each other and share data across platforms, then you can see the signals coming out and you can, drill down into the signals to see, okay, we've got a blip in the wastewater. Do we see anything in the humans or the cows or the birds? And I think that's what it's going to have to come to. But those scientists in those four areas, zoonotic, insect-borne, humans, and public health, they have very different training, and the languages need to be translated. And data is, the universal language in that setting, I believe, because you map it and it's there, and it just does its thing and gives you an alert. So I'm hopeful that some of these things will happen.
Yeah. Well, this has been wonderful. One of the major reasons we have this podcast, Donna, is so that people like you can help inform the industry of what's really needed, as opposed to what their
Yeah.
uninformed
Well,
dreams are.
I hope some of it's useful. And I do think about this a lot, and I do work with a lot of sponsors and vendors because you can't complain that you don't have the test that you want and that people design it poorly if you're not willing to share what you need. Like, nobody's a mind reader here, so you gotta be upfront and say, this would be great. Can you do it? So unfortunately, there's not a lot of opportunities for clinical lab scientists to do that kind of thing. It's all industry talk and like venture people, and so I appreciate the opportunity actually, because it's great for me to be able to say that these are our challenges.
Well, thank you, Donna. You've been a great spokesperson and a wealth of information.
Thanks.
Thank you.
Halteres Presents is produced by Halteres Associates, a US-based bioscience consultancy that provides strategic and tactical services in the areas of diagnostics, medical devices, and life science research to clients of all sizes. The views, information, or opinions expressed during the episode are solely those of the individuals involved, and Halteres Associates is not responsible for any errors or omissions or for the results obtained from the use of this information. The information provided in this episode is for informational or educational purposes only and is not intended or implied to be a substitute for professional medical advice, diagnosis, or treatment. Halteres Associates would like to say thank you to this episode's guest or guests, and thank you for listening to this episode of Halteres Presents.